Hola, buenos días para todos. Gracias por acompañarnos en esta nueva actividad del capítulo argentino de terapia de la mano en este día sábado. Mi nombre es Mariana del Campo y voy a estar junto a la licenciada Paula Címaro en el día de hoy, presentando una charla con un ponente internacional con vasta experiencia. Queríamos recalcar principalmente que esta fue una actividad pensada en función del principal objetivo que nos propusimos al iniciar esta comisión, que fue crear puentes y redes con rehabilitadores, tanto nacionales como internacionales. Chinchalkar tuvo la generosidad de participar en esta charla hoy y permitirnos que su disertación sea abierta a la comunidad para que todos podamos acceder. Les recuerdo que la actividad del día de hoy no va a contar con traducción en simultánea ni subtítulos. Sí los pueden activar una vez que finalice el vivo. ¿Sí? Van a tener la opción disponible para poder verlo con subtítulos. Sin más, les voy a presentar a la licenciada Paula Címaro, ya la conocen, ella es licenciada en terapia ocupacional, miembro certificada del capítulo argentino de terapia de la mano y desarrolla su actividad en el Hospital Italiano de Buenos Aires. Pauli.
Gracias, Mari. Buen día a todos. Bueno, vamos a proceder a continuar esta actividad en inglés, ¿sí? Recuerden que una vez finalizada pueden ver la demanda con incorporar los subtítulos para poder aprovechar la actividad. Bueno, good morning, everybody. It's Saturday morning here in Argentina. There might be people connected from different parts of the world, so thank you, everybody, for taking the time to be here sharing with us. My name is Paula Címaro. I'm part of the executive committee of the Argentine chapter of Hand Therapists, and with my colleague Mariana del Campo, we will be moderating this activity. We would like to thank to our actual president, Cecilia Casasa, for inviting us to participate in her committee. And I would like to introduce you our special guest and today's protagonist, Mr. Shrikant Chinchalkar. He's a great hand therapist, he's an educator and teacher of many, and he has accepted to participate in this activity with a lot of kindness, generosity, and willingness. So thank you very much, Shrikant, for being here, sharing today with us. I'm going to share my screen. First of all, I would like to let you know that when we started working for this committee last year, we proposed ourselves some goals, and one of them was to build networks with national and international hand therapists. So today we have the pleasure to count with the participation of Shrikant Chinchalkar, and he will share with us a lecture about the application of stress on healing tissue. Shrikant has a master's degree in occupational therapy from Nagpur University in India. He worked for 26 years as a senior hand therapist at the Ross McFarlane Hand and Upper Limb Centre from the St. Joseph's Health Centre in London, Ontario, Canada. He has over 50 years of clinical experience in treating upper extremity conditions, nearly 40 years of teaching, and 30 years of research experience. He has designed and developed hand therapy programs at 4 major teaching centers in Canada, including the Ross McFarlane Hand and Upper Limb Center. He designed the most structured hand therapy fellowship program for the training of therapists at this center. He worked as a guest lecturer at the University of Manitoba, University of Toronto, and Western University, and he conducted many instructional courses on upper extremity rehabilitation in over 35 countries in the world and has won many awards for his presentations. He has been awarded the Paul Brand Award of Excellence by the American Society of Hand Therapists, Best Educator by the Western University, Most Outstanding Prestigious Alumni by the Nagpur University in India, Lifetime Membership Award, and Excellence in Teaching and Coaching by the Canadian Society of Hand Therapists. In 2017, The Hand Therapy Fellowship Program was named after him, and it was called Chinchalkar Hand Therapy Fellowship Program at the Rock McFarlane Hand and Upper Limb Center. In 2019, he received a Lifetime Achievement Award by the International Federation of Societies of Hand Therapists in Berlin. He was chosen as an honorary advisor to the Asia Pacific Wrist Association in Seoul, Korea. He served as a member of the Education Committee of the International Federation of Societies for Hand Therapy from 2019 to 2022. And he currently serves on the editorial board of Hand Therapy Journal, published by the British Society of Hand Therapy. He has authored 6 book chapters and has published nearly 50 papers and 15 abstracts in numerous peer-reviewed journals related to upper extremity surgery and therapy. So thank you very much, Shrikant, once again for being here today with us. I think that great professionals inspire others, and I think you inspired many of us, so thank you for that. Thank you again for sharing your experience, and on behalf of the Argentine Association of Hand Surgery and the Argentine chapter of Hand Therapists, I would like to extend our gratefulness for sharing today with us. So we can move forward with your presentation, and I would like to tell the audience that remember them to leave your questions so as we can discuss and share some doubts after Shrikant's presentation.
Thank you, Paula.
Welcome.
Thank you, Paula, and also thank you, Marianne, for bringing me on your platform. And I'm going to present the most exciting topic today. And it may be somewhat controversial too, because there are certain things we can see that these patients definitely require different type of an attention. So if you look at my opening screen, you can see different types of injuries. And the injuries may not be as severe as you see on the screen. They may be simplest injury, but it's very important for us to look at these injuries differently and consider as to how best we as therapists can provide them with motion, function, and ultimately make these individual upper extremity worthwhile so that they can use the extremity quite effectively. So the title of my topic, therefore, is looking at the physiology of stress application on healing tissues. So if you look at the stress that we have used on our body, we can say that it's an age-old technique. Basically, we have used that to modify our human body, modify our body by sculpturing in different fashion, by using tissue expansion or shortening. So in other words, we can say that we have used sustained stretch or compression to modify certain parts of our extremity or body in order for us to have that particular feeling. And then there are various other forms of stress that we have used as humans to enhance our mind, body, and spirit, helping us sculpturing our physique, improving our circulation, improving our function in terms of motion as well as the nervous system. So these two examples tell us that we have used slow and rhythmic type of a motion in order for us to have better circulation, better respiration, and so on. So if you look at overall the benefits of motion, or which we can call a stress, there are a number of physiological studies that have been done in order to find out as to how movement really creates what kind of an effect on different systems that we have in our body. We can say that we have improved cardiac rate, we have improved pulmonary output, our muscles have better excursion, and eventually muscle gets strength. The bone density is well maintained, metabolic function is improvised, and of course it gives us better neurological function. And if you look at all the benefits, we can actually keep an account as to what all the benefits that we can reap from the motion. It's important for us to now look at stress versus rest, which have been applied clinically. So you can see that for the longest time, the tissues were deprived of stress or motion following an injury or a disease process. It was believed that rest is critical factor in allowing these injuries to heal or disease process to heal. But the concept of stress application is now changing. Why? It's because there are a number of changes that have occurred as a result of rest for longer periods of time, which has given us stiffness, limited motion, limited function, and of course, limited cortical orientation of our motion and mobility. So now, because of our understanding of the physiologic processes caused by stresses, we are now changing our thinking process to using stress in a form of emotion in order to modify and sculpture our body following an injury or following a disease process. But before we actually go into discussing the physiologic improvement or physiologic process of stress, it's very essential for us to understand the stages, normal stages of wound healing. When we have a trauma, we can say that the first response, body's response, is an inflammatory process. And this inflammatory process is required to prepare the area for healing. But this inflammatory process gradually over time, because of the vasodilatation, there's an increased abnormal vascular, lymphatic, and of course, motion, that we have as a result of inflammatory process. We have increased volume of fluid in a form of an edema that causes the extremity to have motion towards gravity, and we often see if the hand is involved, then we have a wrist draw. But we know that inflammatory phase then progresses to proliferative phase. And there are a number of activities that goes on physiologically when we are in a phase of proliferation. The main purpose of proliferative phase is to rebuild the structure. And then physiologically, there are a number of changes that occur gradually over time. And this goes on for about 21 days or 3 weeks, or maybe even longer, depending on certain circumstances. So the function of the proliferative phase, therefore, is to rebuild structure, and gradually over time, following epithelialization, when body is dumping the scar tissue in that area where the injury is, you can see that the tissues start to become immobile. And because the tissues become immobile, it definitely entraps the tendon. Tendons have adhesion formation, which then limits excursion of these tendons or musculotendinous structure, giving us stiffness of the joints. And if you look at the proliferative phase, then it changes after about 21 days or so, or more, even slightly more than 21 days. It changes to remodeling phase. Ultimately, the function of the remodeling phase is to provide us with the final form. So this is an injured hand, but over time, of course, as the remodeling occurs over time, then you can see that there is a normalization of various structures. But in general, if you have not introduced stresses right from the beginning, then we'll see that the dumping of the scar tissue in the wound gradually over time during proliferative phase will continue to cause limited excursion, limited motion, limited strength, leading to progressive joint stiffness, making tissues more and more immobile. So in other words, this will lead to immobilization, and the consequences of immobilization, therefore, are many, which we'll look into more details as we go further. But it's very important, besides looking at the phases, what physiological changes or changes we see physiologically as the wound goes from inflammatory phase to proliferative phase to remodeling phase. So we saw already that during inflammatory phase, because of the vasodilatation, there's an increased volume of fluid. So therefore, that increased volume causes deforming position of the wrist and fingers. And if it is left behind like this, then ultimately patients will end up having limited motion of the tendon, limited motion of the joint, Fingers will go into a claw hand deformity, the tendons will tether, and there'll be a progressive stiffness over time. It's important for us to look at the physiological changes that occur during proliferative phase, and we can see that as epithelialization occurs, as the body has the deposition of the scar tissue over time, we see that structures become quite limited. But as the body is laying down the fibroblast in the injured area, the body is already causing a production of GAG stands for glycoaminoglycans. And we'll look at physiologically what exactly the glycoaminoglycans do. And we'll look at that in more details, and then that will base our motion and function in terms of how we mobilize structures in order to achieve what. And then as you progress from proliferative phase to remodeling phase, we see that there is a process continuously that goes on, which is called as a collagen synthesis and collagen lysis. So body is trying to balance between creating a balancing act between the collagen buildup, synthesis means buildup, and lysis means breakdown. So the purpose of collagen buildup and lysis is occurring at a rapid rate to minimize excessive keloid formation or scarring formation in the area which is undergoing healing process from proliferative phase and entering into remodeling phase and continuing to the remodeling phase over time. So based on what we looked at, the processes or changes that are occurring in different phases of wound healing, the question then arises, could we not induce changes so that we can enhance motion, so that we can prevent joint stiffness and maximize mobility of the joints and tendons and overall function of the extremity? So especially, it's important for us to dive deep into various phases even more in order for us to understand why application of stress physiologically is beneficial to gain what. So let's look at proliferative phase, once again going into somewhat more details. So when there is a wound, the epithelial layer from different areas, uninjured areas, are now trying to cover that wound completely so that there is epithelialization, so that the epithelial layer acts like a barrier between the external environment and internal milieu that we have. So in other words, the epithelialization goes on immediately after the inflammatory phase subsides, and then therefore that is causing prevention of bacterial invasion into the open wound. Then around 4-day mark following an injury, the wound starts to shrink, or the process is called as the wound contraction. The adjacent area now, as the body is depositing the scar tissue or adhesions or fibroblasts in that area, it tends to pull the adjacent side closer to each other. By doing so, the body is attempting to close the wound by producing wound contraction. So as the body is laying down the scar tissue in that area, you'll see that gradually over time, the joint surfaces are pulled closer to each other. And as a result, the joint space starts to reduce over time. And as the collagen production becomes a lot more profound over time, and if you have not introduced forces or motion in general, then the articular surfaces are pulled even more closely, causing depletion of tendon gliding, depletion of excursion of the skin and tendons and nerves and muscles and whatnot, leading to reduced motion, leading to joint stiffness. So looking at the more deeper function of the proliferative phase is that at this stage, the body is producing fibroblast, and the main function of the fibroblast deposition, is to start production of glycoaminoglycans. So glycoaminoglycans is sort of a lubrication system that fibroblasts produce. And of course, the motion is primarily responsible for increasing our production of glycoaminoglycans. So some of the animal studies have shown that immobilization of a joint following an injury has a direct effect on production of glycosaminoglycans, and therefore immobilization makes the tissues gradually immobile over time. So then the question arises that then why not introduce early short arc of motion in a controlled manner so that we can enhance production of glycosaminoglycans? Some of you may have heard Don Lalonde speaking about motion. Motion, he says that motion is lotion. Lotion is, in other words, the motion which produces lotion is increasing glycosaminoglycans so that continuously the fibroblasts that are being deposited are lubricated continuously with motion so that there is no adherence of the fibroblasts as they are being deposited to adhere to each other and to the surrounding structures that we have following an injury. Now let's dive more deeply into the remodeling phase so that we can understand the physiological processes that happens during remodeling phase. So we know that the scar changes to fit the tissues it is healing. But in a proliferative phase, the body is trying to dump the scar tissue randomly. So if you look at the orientation of the collagen fibers that are being deposited, we'll see haphazard deposition randomly. They're not specifically organized in a particular manner. So it's like a dumping a cement in that area, which is not uniformly sort of laid properly in order for the adhesions to cause any restriction or limitation. So random orientation of the collagen fiber that is deposited during the proliferative phase definitely will cause restriction of tendon gliding, restriction of joint motion, ultimately gradually causing limitation in motion of the joint. So during remodeling phase, what remodeling phase is responsible for creating a milieu so that collagen buildup continuously happens, but the older collagen that is being laid down are broken down so that there is no massive scar formation or massive keloid formation in the area that has undergone or has been undergoing through the healing process called proliferative phases and so on. So the random orientation of the collagen fibers, during remodeling phase, the body is acting fast together in order to maintain and control the amount of scarring deposited during the remodeling phase. So keep in mind that collagen buildup and lysis is occurring at a rapid rate so that there is a reduction of the scar mass. However, this can be modified so that there is no massive accumulation of the adhesions in a randomly organized manner, which will lead to limitation of motion of the joint, lead to limitation of excursion of the tendon, and ultimately function of the upper extremity. So when we are talking about all these processes, it's important for us to really understand the contracture process, which is much more profound with immobilization. So again, the animal studies have shown that the body goes through various phases following an injury, going from inflammatory phase, and around 4-day mark, there is a process called wound contraction, which we have already discussed. And as the wound starts to contract, definitely it is creating physiological effect on the joint, and joint surfaces are pulled closer to each other, which ultimately will minimize excursion of the tendons, which will minimize motion of the ligamentous structures. And especially when there is a bone on bone, you can very well imagine that gradually over time there'll be arthrosis or degenerative changes that are likely to happen at the intra-articular level. And then in proliferative phase, of course, this is magnified over time as we discussed in details. And if motion is not introduced in early phases of healing, then of course, by the time the wound enters into a remodeling phase, you have already stiff joints and there is a dense scar formation in the area that has undergone an injury and going through all these healing process and so on. So when you have a dense scar, the scar limits motion, And especially you can imagine that when you attempt motion at a joint, there is a greater amount of translatory force that causes compression of the articular surfaces, which may then go on to degenerative processes, as I mentioned earlier. So ultimately, what we have in our hands is a stiff joint and stiff joints or stiff extremity. So in general, if you look at and break it down, the contracture process or contracture formation, it is seen on animal studies that the development of contracture is very profound in first 3 weeks following trauma or following an injury. So now let's look at details of the physiologic process that is caused by immobilization. We know that you have quite a bit of pain. So my philosophy is the stiffer you are, the more painful you're going to be. The more we start to gain motion, you become pain-free, 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 and so on. And ultimately, you are relieved of pain, and of course, you have motion. So physiological effects of immobilization, therefore, is we have increased pain when we attempt motion, because every sensory structure is affected as a result of immobility, besides having a limitation in excursion of the tendons, ligaments, and so on and so forth. And of course, we know that limited motion definitely will have an effect on the mobility of the joint. And as the structures become a lot more immobile and have lost excursion, then as you push or attempt motion, you have an increased joint compressive force. And we know that you need motion in order to have an enhanced bone mineralization and so on. But if the extremity is immobilized, then you have bony changes, the muscles become atrophied gradually over time, and then you have what is called as a decreased joint hydrodynamic. So as a result of this, you have a reduced vascular and lymphatic function, one, and two, you have a reduced hemodynamics, means blood flow. Motion stimulates arterial flow, venous and lymphatic return that is affected as a result of loss of mobility. And especially the nerves that are responsible for detecting tension and regulation of muscles, they no longer appropriately function. So as a result, the nerve are not producing any or sending any information to your motor and sensory cortices, and as a result, you have a reduced nerve function as well. And physiologically, there are a number of complications that you're likely to see as a result of immobilization. So far we looked at the stages of wound healing. So far we looked at the consequences of immobilization and contracture formation. But it's important for us to take into account the effect of immobilization physiologically as to how bad it is on our functioning of the extremity. So now it leads us to even dive deeper to look at what exactly happens when you immobilize. And we know that we'll have a contracture formation as a result of immobility, but we know that consequences of immobilization will definitely have a detrimental effect on number of factors that are responsible for allowing tissue pliability. So again, the animal studies have shown that trauma followed by immobilization tends to contribute the contractile protein, which is called as actin, in fibroblasts. And Kevin Hildebrand from University of Calgary has shown that some scar formation or adhesion formation or contracture formation, which has a contractile protein as an actin, will also show myofibroblastic activity or greater number of myofibroblastic deposition in the area where the injury is. And then, of course, it has been identified that immobilization definitely will produce adhesion formation between the tissues that move normally. In other words, you have tendons that are gliding back and forth as you're performing motion. If you have limited flexion, then extensors are affected. And if you have limited extension, your flexors are affected. And on top of that, it will have a detrimental effect on your joint capsule and, of course, ligamentous structure. And why does that happen? Because there is an abnormal cross-linkage buildup between the structures that move normally. And then some studies have shown that muscles, because they have lost excursion from full extension to flexion, the sarcomeres are reduced, so the muscles are shortened, and then of course, because there is no motion, there is a loss of viscoelastic properties of the tissue, which ultimately leads to joint stiffness. So far we have walked through all the mechanism and processes that leads to joint stiffness, and we have looked at various physiological processes that goes on as a result of an injury, first of all, and secondly, it goes on as a result of immobility, and we have looked deeper into various other physiological factors that leads to, of course, limited motion scar formation, loss of motion, loss of function. So then we need to ask ourselves a question. Physiologically then, what effect would stress have as the tissues are going from an inflammatory phase to proliferative phase and entering into remodeling phase, and what is the final outcome we are going to achieve through application of stresses? So let's look at the collagen buildup and all that we talked about. So as we know that during proliferative phase, the collagen is randomly deposited in abnormal manner. There is no particular organization of the collagen fibers or scar tissue. So as a result, we see a dense scar formation. So the question arises that if the dense scar is formed in various regions, because scar, we know that it attempts to mimic the characteristics of the tissues it is healing. So we can see that if we have a dense scar, it will have a highly cross-linked scar, as I discussed earlier. But the question arises whether we can convert the dense scar tissue as it is being deposited, can we make that a pliable tissue? And the answer is yes, we can make that dense scar tissue formation into a pliable tissue which has a loosely coiled scar, and that loosely coiled scar definitely works to our advantage. And we can call this as an induction theory. So when we allow motion, when we produce stress, of course, control stress on the healing tissues, we can make this dense scar, which is randomly deposited in haphazard manner, we can allow this scar tissue to organize in a way that these adhesions that are forming as the process begins from the proliferative phase, entering into remodeling, and ultimately, finally, the motion will allow reorganization of these collagen fibers in a linear direction so that it doesn't produce a restrictive effect, limiting motion of the joint, excursion of the tendons, and so on. So induction, so we are inducing changes. But what would change the behavior of the fibroblast by the scar tissue and collagen fiber? We can say that motion induces changes which will produce a linear orientation of scar and adhesions to our advantage, so that this linearly organized adhesions of scars definitely works to our advantage, which is not causing restriction of tendon motion and joint. But in order for us to do that or induce a change in the behavior of the scar tissue that is being produced at the fibroblastic or proliferative phase, we need to add something that is called as a tension. So we can name this as a tension theory, because the tension theory is introducing stresses that will have an effect on the wound area during the phases of healing. So we can divide these tension theories into an internal tension and external tension. So internal and external tension, therefore, will have a physiological effect on structures that is undergoing healing process, right from the inflammatory phase and onward. And of course, by the time person enters into a remodeling phase, because we have already introduced stresses right in the beginning, we can have a successful remodeling of these tissues, which is going through all these physiological phases. So Dr. Paul Brand taught us that low load, long duration of stresses definitely are beneficial, or in other words, we can begin with slow and rhythmic motion right from the early stages of wound healing in order to create a physiological change and, of course, produce or induce what we call a successful remodeling of the scar tissue or injury that is undergoing those phases and so on. So now we are going to look into the physiological principles of management based on the stages of healing. What should we do during inflammatory phase? What can we do during proliferative phase, and how we can maximize mobility in remodeling phases? So let's look at the breakdown of the wound healing phases into different factors. So we know that literature talks about the inflammatory phase that may go on somewhere between 3 to 4 or maybe 5 days following an injury. So this then enters into a proliferative phase for about 21 days or maybe somewhat longer. And then after 21 days or somewhat longer, will enter into a remodeling phase over time. And the remodeling phase will continue for quite some time until the tissues have normalized its viscoelastic properties, especially with our physiological management. So during inflammatory phase, we may consider producing some rest. And then as the person is entering into proliferative phase, we can begin introducing some stresses. So at this stage, in the early stages of proliferation, for example, here, we can begin with progressive short arc of active control motion. If the patient has difficulty generating tension at the musculotendinous level, we can start performing active assisted range of motion, going to or progressing to active motion. And then as the person is entering closer or moving towards the remodeling phase, during proliferative phase, we can start introducing dynamic or static progressive splinting as we are coming closer to 3-week mark for that matter. And then in remodeling phase, we can use passive range of motion, static progressive splinting, active range of motion and strengthening. So this is the general framework that we can probably work on in order to maximize the mobility following an injury. So actually, I have trained our surgeons to think from this point of view. So whenever they are operating on a patient, whether it be extensor tendon injury, flexor tendon injury, fractures, or wrist fracture dislocation or elbow fracture dislocation, they are right in the operating room fixing all these things that have been injured, and they have this X-ray scanning machine under which they can look at how much motion could be permissible in order for the therapist to start with controlled motion program. So the stress, which I call motion is the stress. So we can divide these stress into 3 actually different stages. So we can say that internal stresses. So internal stresses mean that we are using active motion, means allowing muscles and tendons to move, starting off with short arc of motion and then going into strengthening gradually over time. So the muscles that are acting and producing motion at a joint, we can call this as an internal stresses. But sometimes because of the adhesion formation is such that the internal forces are probably not enough to create a physiological change of the joint capsule or the scar tissue that is in the vicinity of the injury, then of course external stresses need to be introduced. And these external stresses can be categorized into joint mobilization, passive range of motion, any form of splinting. We can use electrical stimulation to enhance muscular function so that we can maximize internal stresses and so on, or use continuous passive motion. Or at a later stage, after we have used internal and external stresses, during the process of our management, we may have to combine internal and external stresses in order for us to have greater amount of motion and so on. And the examples being place and hold, dynamic assist splinting, or EMG triggered electrical stimulation. So here, of course, you'll see that I have not included casting motion to mobilize stiffness, because having practiced this in my clinical practice for number of years and having trained our surgeons to think from this point of view, I have not really needed the casting motion to mobilize stiffness in my clinical practice. And this goes on at my facility at Roth McFarlane Hand and Upper Limb Center. So the question arises, how do we apply the stresses and what kind? So you can say that internal stresses can be applied safely during the late phases of inflammatory periods and early periods of proliferative phases. So this is basically using muscle and tendinous unit, starting off with active assisted range of motion, progressing to active range of motion, or if the active range of motion is possible for this individual, then begin with active range of motion, and then, of course, range of motion that is in a form of a control motion program. So we start off with short arc of motion. Short, safe arc of motion at certain stage, even in early stages of inflammation, late stages of inflammatory process and proliferative periods. And then you increase the amplitude of motion gradually over time as the tissues have regained some strength, tensile strength, and of course the motion. So surgeons at times are worried that this motion is going to cause disruption of the tissue repair or tissue failure. So we must educate them that the short arc of motion definitely is going to produce minimal stress. And there are a number of studies that are emerging out talking about the application of stress causing faster angiogenesis, means faster blood healing and faster blood supply as we perform motion with a limited arc, and then gradually increasing arc will increase motion again. So how did I come to, or how did I learn this? This is based on one of my patients who was referred to me. So this patient had a motor vehicle accident. He is 28-year-old right-hand male traveling as a passenger with his friend, with his hand on the sunroof. The driver who was driving the vehicle lost control and the vehicle turned upside down. And then, of course, the patient had scraping of the dorsum of his wrist. You can see the tendons here. The joint surfaces are exposed, as you can see. So this is a drastic injury. So patient was brought to emergency room. He had on examination, he had a dorsal skin defect. He had a fracture of distal radius, fracture of ulnar head. He had exposed carpal bones and shredded tendons. And of course, this patient needed an immediate surgical attention. So as a result, he had ischial tuberosity bone graft with open reduction and interfixation, which was done by plating and screws. The tendons were taken from the legs, and he had a primary tendon graft procedure in order to construct the extensor tendons again. And then, of course, because there was a big defect of the skin on the dorsum of the wrist, he required radial forearm flap from the contralateral side. And all the wounds were closed. And of course, he had the skin grafting done wherever it was necessary to provide coverage, skin coverage to the injured area. So the surgeon referred the case to hand therapy. On the 7th postoperative day, he had written a diagnosis of what exactly the surgeon had done in the operating room. And the treatment, hand therapy treatment, stated immobilize, which was written in capital form, wrist in 30 degrees of extension, MCP and IP joint in neutral, thumb in full abduction for 4 weeks. Motion only after 4 weeks is stable, and these two lines were underlined multiple times. The surgeon was emphasizing that the therapist or I must follow these two prescriptions, that is immobilize and motion only after 4 weeks. So having looked at his OR note, it's very important for you to refer to the operative note for you to have and gather all the pertinent information based on which you sort of structure your therapy program for these individuals. So looking at his OR note, obviously, I kept on making a list as to what will happen if the wrist and fingers are immobilized for this length of time. So I identified that he'll end up having scarring of the dorsal wrist joint capsule, and then the tendon graft will stick to each other. There won't be much of motion of the wrist and forearm. And because the fingers are not mobilized, the wrist is not mobilized, patient is likely of having profound MCP and IP joint stiffness, and eventually the hand will become like a paddle. And of course, this is not really what we would like to see happen to these patients. And if the patient ends up having stiffness and tendon adhesions, it's quite likely that the patient may require multiple stage surgical reconstructive procedures. And we know that these reconstructive procedures are staged somewhere between 4 to 6 months apart. So that means that overall, the patient will require surgery, therapy, surgery, therapy, and this will go on for at least 2 to 3 years following an injury that patient had, and patients will end up having limited function of his upper extremity, and the results definitely will be unpredictable. So this is not what hand therapy is all about. Hand therapy should be based on the injury, the surgical procedures, and a thinking process as to what we can do to minimize multiple surgery and therapy. And then what can we do? We can maximize the mobility, especially for this individual. So we proposed the program that looking at the referral on the 7th postoperative day, it's obvious that the patient is already in a proliferative stage of wound healing. So at this stage, why not initiate early controlled short arc of motion of the wrist and MCP joint with the dynamic splinting? There are various studies that have been done previously that had talked about early controlled mobilization program. And one being Kleinert, who introduced using rubber band traction method to mobilize the tendons, flex the tendons. So why not we use the Kleinert principle and apply this in this situation so that we perform controlled motion, allowing short arc of wrist and MCP joint motion in isolation, so that we can gradually increase motion at the wrist and gradually increase motion of the MCP and IP joint. And then at this stage, we can begin with early active forearm rotation with tissue restraints, and then gradually increase arc of motion by 10 degrees at the wrist and 15 degrees on a weekly basis, and then introduce gentle passive at a specific stage, and then use CPM because of the massive injury that he had suffered. And then progress his range of motion as he recovers over time. So the consequences, it's important for us to weigh the benefits of immobilization and weigh the benefits of mobilization and compare the two and identify whether immobilization is beneficial or whether mobilization gives you a greater benefit. We have to see which one outweighs the other in order for us to make a decision. So looking at the consequences of the program that I propose to the surgeon, we can say that, yeah, gradually we can gain motion at the level of the wrist and fingers. We can recover range of motion. It will enhance, help remodeling of the adhesions in the direction of stresses, as we discussed earlier. And as we recover the range of motion, the muscle function will definitely improve, and the patients will definitely have an early return to normal lifestyle. So in general, by allowing controlled motion program over time, we can definitely shorten the rehab time significantly. Except it's quite likely that patients may have a rupture of 1 or 2 tendons because of the stresses that we are applying. However, if the motion is in a controlled manner, it's less likely that you would rupture a tendon. So this was presented to the surgeon, and of course the proposed program was accepted by the surgeon, and of course we had to introduce this proposed program to the patient by giving him full education about the benefits of motion versus disbenefits of immobilization. So the patient agreed, and we drafted a consent form and asked the patient to sign that he is in agreement with the proposed program, and he understands the benefits and, of course, the consequences of the mobilization, and is in full agreement and will allow us to start using the proposed program. So now, of course, we looked at his injury. We identified that mobilization is most beneficial than immobilization. And of course, we looked at the benefits of both. And of course, the mobilization outweighed immobilization process. So based on this, we formed a further definition as to we want to mobilize. So it's very important for us to see we mobilize what and why, and then how much mobility should we allow the persons to have. And then the other factor is how do we immobilize, because there's a massive injury, primary reconstruction of the tendon using tendon graft, and the tendon graft has to heal distally as well as proximally. So that means that there are two sites where the tendon graft should sort of start recovering blood supply and all that. So keeping all this in mind, we had to create a framework of our action. And the framework of our action, of course, was based on the structural involvement and repair. So now remember, the patient is 7 days post-op, means he's already in a proliferative phase. So we started off with the dynamic splinting. So wrist hinge dynamic splint, we allowed him to perform isolated wrist flexion extension, and of course finger flexion extension based on the Kleinert principle. So what does Kleinert principle tell us? That when we perform motion against resistance, there is a synergistic relaxation of opposing group of muscles. So this he introduced when he was treating flexor tendon repairs. So he used rubber band traction of his fingers. When the flexor tendons were repaired, patients were encouraged to perform resisted extension. And he identified that as the person is performing resisted extension, the flexors are synergistically relaxing, and therefore the flexor tendons are not receiving failure amount of stresses at the repair side. So same principles we applied here, but on the extensor side, and then gradually over time. So patient was fitted with the dynamic double reverse Kleinert splint. We allowed him to use the splint for a period of about 4 weeks. And of course, we knew that there was a muscular trauma. So therefore, we used electrical stimulation to increase muscular efficiency so that the tendons can glide. And then, of course, we also knew that he had suffered quite a bit of trauma to the tendons as well as the articular surfaces. We didn't want the tendons to adhere at the wrist level. So therefore, during the day, he went through the mobilization program, periodic electrical stimulation 3 times a day for about for 10 minutes for flexors, 10 minutes for extensors, and then the remaining time he used the wrist CPM, but intermittently he would come out and perform active range of motion of his wrist and fingers. So the CPM, he used it at night so that in the morning when he woke up, he is not stiffer. So whatever motion that we have gained during the day was retained at night so that we don't have to start from square one again on his next visit. So ultimately, he showed remarkable improvement. Fortunately, none of these tendons were ruptured, but if they had ruptured, we still have some spare parts in our body which could be used to reconstruct or repair those tendons or use tendon graft. So benefit here is, of course, we gain motion and we follow these patients up for a period of about 5 years. Of course, well, not really 5 years per se, but he dropped in one day to thank us for providing him with greater amount of mobility for his fingers. So this is the reconstructed finger extensor tendon showing excellent results. So it's not applicable to wrist alone or extensor tendons alone, but let's look at flexor tendon management now, which has evolved over time. So of course, if you look at the rationale, physiological rationale of allowing these persons to perform early control motion program, and the work was done by Wu and Tang, which is published in Hand Clinics. So motion definitely helps stimulating increased vascular supply, which is beneficial because of motion. And since we are introducing motion right in early stages following tendon repair, it helps in stimulating tenocytes and maturation process and continues to remodel the tendons over time. And as you allow these persons to perform control motion program, the tensile strength gradually increases. And of course, since the patient is performing control motion, the tendons have better excursion properties. So how we do that? We allow the person to perform short arc of motion in week 1, and then gradually will increase arc of motion to moderate flexion in week 2, so that the person is moving the fingers in mid-range with low resistance of flexion. And then gradually over time, by 4 weeks, we allow the persons to carry on with motion and reach extreme flexion, of course, definitely with caution. So gradually over time, as you're increasing motion of the tendon is gliding back and forth, not having any attempt or chance of forming adhesion formation. So the reason that we do active motion in flexion and extension in early stages definitely has shown us that we need to allow the tendons to move in a bidirectional motion. So when the person performs flexion, the tendon is moving proximally. When we allow the persons to extend the metacarpophalangeal joint and interphalangeal joint, the flexor tendon is moving distally. So the gliding of the tendon is bidirectional. And by doing so, we can see that the arc of motion definitely is much better. But if you look at the articles written on flexor tendons, you can see that early control motion program was first, the concept of early control motion program was first introduced by Gelberman back in 1980. And it took us so many years. So 20 and 20, so maybe it took us 30 years to recognize and realize that Gelberman had already mentioned that early active motion is beneficial in allowing the tendons to have a better vascularity and better outcome. So we were 30 years late in allowing these patients to perform bidirectional motion of the tendon by allowing them to have control motion program. So how we do that? We have design programs so patients only perform flexion to a vertical distance. And then they also perform wrist stenodesis, wrist extension, finger flexion, and then assist flexion of the IP joint during wrist extension and finger extension with wrist in flex position. And the results of zone 1 and zone 2 injuries and even other injuries of the flexor tendon zones definitely gives us excellent results, as you can see right here. So what have we achieved by allowing these patients to have a control motion program? So looking at some of the work that was done by Jean-Claude Goimbertu, which has shown that motion of the tendon in a controlled manner definitely enhances vascularity. And of course, by allowing the tendons to move, this helps in stimulating tenocytes maturation process. The tensile strength definitely improves. And of course, the tendon has a better excursion property. So let's look at a few other cases just for our interest to see whether it is applicable to other forms of injuries as well. So this fellow had a PIP joint dislocation. As you can see, it's quite drastic. And then if you look at the healing of the tendons, the studies have shown that controlled load and motion has helped the tendons the ligaments to heal properly. And therefore, the studies have shown that when you allow controlled load and motion of the fingers following a ligamentous injury, it helps in increasing collagen buildup and collagen matrix organization and reorganization as you allow the person to flex and extend the finger in a controlled manner. And the studies have also shown on the ligamentous injury that when you introduce motion to the fingers in a controlled manner, you have a more rapid return of normal tissue DNA content. And eventually, you will have an increased tensile strength. So if you look at the collagen orientation of the ligamentous structures, we know that the ligaments have reduced or lesser blood supply as compared to various other structures. So therefore, the ligaments highly depend on control motion program in order for them to have a rapid return of DNA content and, of course, having increased tensile strength. And ultimately, when you achieve that, then you have a greater motion of the joints. And this is the patient's motion after a structured therapy, which we used right from the inflammatory phase until patient went on to the remodeling phases and so on. So now let's look at a few other examples just for us to sort of build up on what we have learned so far. So this patient, of course, had distal radius fracture. And of course, the external fixator is no longer in practice in many parts of the world, except it is still being used in various parts of the world as well. For example, in Southeast Asia and all that. So this individual had open reduction and internal fixation with X-fix, external fixator for distal radius fracture. So patient was brought in for follow-up. He was not referred to hand therapy. So the surgeon, when he saw him for follow-up, he identified that the person or patient is unable to flex and extend the digits due to adhesions of extensor tendons, as you can see here. But the flexor tendons also had limited excursion, because if the tendons are stuck right there or healed here, it has a drastic effect on the flexor tendons on the volar side as well. And he's starting to develop some stiffness because of loss of excursion of the tendons. And the surgeon therefore referred him to hand therapy at 3 weeks after surgery. So we initiated passive and active range of motion for him, and then we progressed to resisted extension and flexion program. And after the fix was removed, we initiated with passive range of motion and active range of motion of the wrist and forearm. And then, of course, we introduced static progressive splinting when he was in a late remodeling phases of his healing. So what we did, so here, of course, if you look at his tendinous orientation, he has a limitation in flexion of the MCP and IP joints because the adhesions were restricting the tendon motion distally. And he had difficulty extending the fingers because the tendons were having difficulty having an excursion proximally because of the adhesion. So in order for us to have this adhesions that is between the tendons and the skeletal structures, we need to have the bidirectional motion. So we encourage the person to perform resisted extension using TheraBand and squeezing a foam ball on the volar side. And by the time the fixator came off, the patient had full active extension of his MCP, PIP, and DIP joint. Keep in mind that if a person has an extensor lag or persistent extensor lag for longer periods of time, the patient will have an adaptive shortening of the intraosseous muscle. And this intraosseous muscle adaptive shortening will eventually lead to excessive intraosseous load at the IP joint, resulting into a secondary swan neck deformity. So the changes will be so drastic that they will be irreversible, and then patients will require additional surgical intervention in order to minimize hyperextension tendency at the PIP joint. So looking at some of these cases, we can sort of question ourselves that how did these changes occur? Means in terms of patients regaining motion, again having excursion of the tendons. So we can say that when if the body doesn't stop laying scar tissue, the body doesn't stop adhesion formation, but we can definitely remodel the adhesion that have formed in the direction of stresses. So by allowing the person to perform resisted extension, as you saw in the previous case, or allowing the person to perform active control motion, whether it be the extensor tendon graft that you saw in the first case, and then of course the flexor tendon repair in the second case, we are, by using stresses or application of these stresses, is causing remodeling of the adhesion in the direction of stresses, so that these adhesions are linearly placed or oriented, so that they are not offering any resistance or significant restriction of tendon motion and eventually motion of the joint. And then secondly, if you look at the fibroplasia period or proliferative phases of wound healing, the early control motion program is gradually building up and improving the influx or increasing the influx of glycoaminoglycans, that is producing greater amount of arterial flow, venous and lymphatic return as well. And ultimately, by introducing stresses appropriately at appropriate stages, right from the beginning, has helped us with those cases improve in range of motion and strength. So now I'm going to bring you somewhat to a different behavior of the scar tissue. So if you look at the scar tissue and apply a load on the scar tissue, it has a vertical displacement. But the moment you let go the load until it reached the specific point, you'll see that the scar tissue will abruptly recoil back to its resting position with the same speed. But if you look at the load placed on the normal tissue, you'll have a greater displacement, and the moment you let go the load, it is going to follow a different path, returning back to the resting position. So what does this tell you? So this tells us that scar tissue lacks viscoelastic properties because of being less elastic and less viscous. There is an abrupt return of the scar tissue to the resting position as compared to the normal tissue. So our purpose is that we sort of introduce forces specifically so that the scar tissue starts to behave like a normal tissue. And we can do that by application of stresses, because these stresses, as I mentioned earlier, helps in increasing the influx of glycoaminoglycan. So application of stresses, so as I mentioned earlier, that you use specific motion for a specific, in a specific phase, but let's look at external stresses when they are safer to apply. So external stresses can be applied during the middle or late proliferative phase and continue throughout the remodeling phases of wound healing or tissue healing. So external stresses are in a form of a joint mobilization, passive range, the splinting, and then you can use electrical stimulation and continuous passive motion. So the purpose of application of stress is that we want to increase mobility of a joint through external means by using these techniques, so that we can gradually work on improving muscle function and gliding of the tendons. But let's look at some of the work that have been done by various authors. And Brand and Frank et al. Have mentioned in their literature that any elongation of the tissue which is accomplished by means of passive range of motion, splinting, and joint mobilization will shorten again once the forces are relaxed and not maintained throughout active motion. So means that you have done passive range, but after about 2 hours, you see often patient complain that, oh, whatever motion that I had, when I left therapy yesterday, it's all gone. And then when the patient comes to therapy again, the patient says that, oh, I'm back to being stiff again. So that means that there's definitely active motion is lacking. Temporarily, we have gained elastic element of the structures that is undergoing healing, But since we have not actively introduced forces by active muscular contraction, we have not created viscous element of the tissue that is healing. So again, they emphasize that the ligaments will return to pre-stretch length, and therefore, when this happens, we can say that especially this thing will happen when stress application in terms of frequency, duration, and intensity is lower. Cyriax also somewhat alluded to the fact that the loss of motion in a capsular pattern will indicate pathology of the entire synovium and joint capsule. And especially he identified that when you have a capsular pattern of immobility caused by the synovium and joint capsule, patients often will demonstrate or show protective muscle guarding, and he said that the protective muscle guarding may be definitely present. So how do we look at the compliance of the structures that is responsible for maintaining motion, maintaining mobility, and so on? So the concept of load displacement curve was introduced by Dr. Paul Brand. He identified that you look at the displacement of the soft tissue and look at its compliance in relation to forces applied. So unfortunately, we don't have a system that gives us a gradation of stiffness. But if you look at the gradation of stiffness, is truly based on the symptom that we identify. So there is no formal gradation, there is no neurovascular contribution in general. And typically when we analyze these soft tissue structures, we can see that the stiffness we analyze by assessing what we call an end feel. For example, if you apply a load to a tissue, it has a greater displacement. So that shows that there is a normal tissue. But if you continuously keep on applying a load, it's quite likely that the normal tissue will reach to a point where there is a failure of it sustaining additional load. Whereas if the graph is like this, having a greater deflection in terms of load applied, we can term that as springy. But if the graph is somewhat vertical, we quantify this as a hard end feel. So if you look at the tissues and its behavior, you have a greater compliance of the normal tissue, limited compliance of the springy end feel, and no compliance whatsoever or somewhat in a hard end feel. So this tells us that we can categorize the patterns of soft tissue representation when we exert a load on the tissues as we consider mobilization. So treatment, of course, we base our treatment by addressing the compliance of the soft tissue to the load applied, whether it be internal or external. And based on that, we identify that these end fields definitely require specific attention. For example, if it is a hard end field, you definitely will need to use static progressive splinting, serial splinting, in order to maintain the compliance of the tissue gains that you have. You may consider using CPM, or you may also consider using progressive stress relaxation technique. So ultimately, the goal is to bring the hard end feel closer to the springy and going from springy to the normal end feel so that the tissues have greater amount of elastic properties and tissues on return we have a greater amount of viscous properties. In other words, the tissues must regain elastic or viscoelastic properties in general through our therapy means. So the physiological benefits of mobilization we know that very well. It helps in improving muscle function, joint hydrodynamics, and of course improves nerve function. And similarly, we understand the passive range of motion and its benefits. And so we are using, especially with hard end feel, we are using external ways of mobilizing or gaining elastic structures, elastic mobility of various structures. But in general, as what Brand and Cyriax said, that physiological effect of this will definitely create some physiological change. For example, if the structures are tight, when you apply a load and unload, you will see that abrupt return of the scar tissue, abrupt return to the resting position, but continuation of therapy over time will definitely create a physiological change in the tissues by creating what we call as a creep. So as you're loading, and dosages of loading and unloading is continuous several times during the day over a certain length of time, over time you will definitely see a physiological change, because these structures that were offering greater amount of resistance will undergo stress relaxation or relaxation phase, and ultimately you'll definitely see a creep over time with motion and of course application of stress. So in other words, there are few concepts that were introduced by various authors. For example, Ken Flowers introduced the concept of total end range time, whereas the Celeste and of course Glasgow from Australia introduced a concept of daily end range time. So in other words, what these two authors meant actually, that in order for you to create a creep or elongation or lengthening of the soft tissue structure that has undergone healing, you need repeated motion for a sustained period of time, several times during the day, in order for you to create a physiological change of the tissues so that they have a permanent deformation with therapeutic intervention. So by introducing these forces gradually and treating these patients in therapy by means of internal and external stresses, internal stresses, combination of those two will enable the person to have greater amount of motion. So this patient had terrible triad. He had an elbow fracture dislocation. Number of structures were repaired, and here he's showing that he's able to have full range of motion from extension to flexion. And on top of that, he is capable of using a weight on his hand and build up the muscle strength on flexors and extensors together. So it's essential for us to look at what are these factors that has properties of healing tissue. So physiologically, you can see that joint mobilization, passive range, or splinting, the physiological effects are short-lived. In order for us to maintain this physiologic change that we have created in a form of a creep, we must introduce active range of motion and muscle strengthening in order for these patients to have a better outcome. So external stresses in general increases passive mobility, which helps improve tissue elasticity. On the other hand, once we have gained some tissue elasticity, when we introduce active motion and strengthening, using internal stresses, then we can create active mobility, which helps in improving tissue's viscous property. As you saw, that active motion, resisted motion, definitely increases arterial flow, venous and lymphatic return, and jointly together gives us better viscoelastic properties. So therefore, combination of internal and external stresses at certain point of their recovery from the inflammatory phase to remodeling phase helps gradually over time reorientating the collagen fibers, reducing joint degenerative processes. It helps in minimizing bone, tendon, and ligamentous atrophy, minimizes muscle atrophy, stimulates actin and myosin glides. And as you gain more and more amount of motion, then you have lesser and lesser pain in the joint or extremity. So stiffer you are, the more painful you are going to be. And as you gain more and more motion, lesser painful you will be as you gain more motion. So physiological benefits of active motion we have gone through in details right from the beginning. And this is something that we have to keep in mind, that we ultimately want to have a superior outcome of our therapeutic intervention. And by application of stresses, we can definitely create better physiological change in the tissues that is undergoing healing process. And there are tons and tons of articles, but some of the articles are here. Like you can refer to Brand, Salter, Gelberman, Amadio, and all that. So look at few clinical examples and then tie it up eventually. So this is a fracture, proximal phalangeal fracture, requiring open reduction and ankle fixation at 6 days following an injury. He had a limited extension and limited flexion. He was placed in an intrinsic plus splint. 2 weeks later, his sutures were removed. Still, there was no much of a change in his range of motion. And at this stage, we introduced tendon acceleration program. So here, of course, we fabricated a thermoplastic splint based on Sarmiento principle, and then allowed the person to perform resisted extension and resisted flexion. And of course, we did passive range and so on. So we worked on the passive mobility and then active mobility as well. So the results are remarkable. So you can see that he has full range of motion, no restriction of motion whatsoever. And this is achievable through definitely planning a specific treatment program for this individual. So here's the patient with multi-tissue trauma, showing range of motion of her fingers. Of course, here we had to keep in mind that the person had a denervation of her intrinsics, and we knew that the surgically, each and every nerve that is connecting to lumbricals and introstia could not be connected. So therefore, we had to induce some amount of flexion contracture at the metacarpophalangeal joint so that the person doesn't have a claw hand deformity. We know the consequences of denervation of intraosseous muscles, so therefore that is something which we had to keep in mind. Here the person has a disarticulation of the wrist, and here you can see the person's mobility is nearly 80% range of motion of the wrist, and of course he has full range of motion of his fingers. He needed just a minor revision, release of his web space tightness that we can see right here. So he needed just a minor release right here. And then, of course, this is the patient who I have used right in the initial introduction of wound healing. You can see that we had to customize his therapy program because there are multiple tendons that were affected. And he also had a fracture, both bone fracture. And of course, we had to get superficialis and profundus of index moving away and proximally to the long and so on. And customization of therapy definitely gave him better range and better strength. So the concept of stress application definitely works, but we have to be cautious when we are exerting stresses on various injuries. So keep in mind that patients may, especially if it happens to an elbow fracture dislocation, like a terrible triad, it's quite likely that application of stresses may fail because there is a presence of drop sign. So these are some of the details that one must keep in mind. And if the patient does not show any improvement over 3 to 4 weeks duration, obviously there may be some intrinsic factors that is not allowing the application of stress to be that effective. And then patient is demonstrating or reporting of pain with loss of motion. And if we continuously keep on applying stresses, then it may cause proximal or distal joint instability. So if the patient is not showing any change over I would not wait for 3 to 4 weeks, but I would, if the patient has not shown any improvement over 2 to 3 weeks period of time with application of stresses, patients must undergo some further investigation radiologically, or patients may require ET, CT, or MRI. And then it's important that hard end feel may be due to bone on bone, or patients may have heterotopic ossificans, as you see in this slide. So this lady had a terrible triad. She had a proximal radial synostosis around 2-week mark. When we see that patient is not recovering, on the contrary, the patient is complaining of pain and discomfort at her elbow and also at the level of the wrist. Since we were applying forces to rotate her forearm, we brought the patient back in the surgeon's office, investigated her through radiologically, and we identified that she had radioulnar synostosis and required release of radioulnar bony healing, and then afterwards we applied those stresses again. So these are the cases you saw on the opening slide. You can see that this person has multiple flexor tendon repairs showing range of motion. This is a patient who had a hand replant, and of course, here he is playing golf. This is the patient who had a multiple metacarpal fractures, an industrial accident where his metacarpals were fixated, tendons were repaired, showing his range of motion. This is the lady that you saw, especially earlier, who had a transmetacarpal amputation, working on 9-hole pectus, and this is a bad injury of the forearm, fracture, and of course, dislocation, showing range of motion of his fingers. So in conclusion, internal and external stresses affect the wound area during healing phases. I've gone through many details, and I think this is something that we have to keep in mind, that for successful remodeling, we need to introduce the forces, but the forces must be introduced right from early or late stages of inflammatory process and continue through proliferative phase, and then continue through remodeling phases until we gain range of motion and, of course, excursion of the tendon. So studies have shown that stresses and strain, when applied correctly, produces greater physiological change during tissue healing. And therefore, early controlled mobilization must be considered for optimum results. So physiological effect of stress on healing tissues, we have gone through in detail, and this is something that we have to keep in mind. But these are not the only benefits that one is going to achieve when you are applying stresses, but there are many more physiological changes that occur at the cortex level, motor and sensory cortexes. It also improves physiologically our metabolic activities, and of course, all our systems are in sync with motion of our extremity. And therefore, motion is lotion, and therefore this lotion needs to be increased through controlled stresses. And this concludes my presentation on physiological benefits of application of stresses on healing tissues. Thank you.
Well, thank you so much, Shrikant, for your presentation. It's always a pleasure to listen to your lectures. So thank you for letting us to learn from your wide experience, and to remember to all of us the importance to taking into account the physiology that is underlying the application of stress on healing tissues. And of course, the impact of our interventions in order to take the appropriate treatment decisions. I think it's also important to highlight the necessity of teamwork so as to receive the patient in early stages, to be able to implement strategies that allow us not only to treat the patient, but also to prevent complications, as you mentioned. So we have some problems with the chat, but some of the participants send us their questions. I can read it to you and we can discuss them. The first one is, do you use silicone pads for scar treatments, and which are the criteria to prescribe them and when?
So it's an excellent question. Many times we see some keloid formation, and therefore we have to use the silicone pad. So how does this silicone pad or pressure garments really work on the scar tissue? So as I mentioned, that scar buildup, the collagen buildup is oxygen dependent. So if there is a greater amount of oxygen supply, the scar buildup will be relatively a lot more profound. So in such situation, when you apply a silicone insert, it causes depletion of the scar buildup and improves the ratio between scar buildup and scar breakdown. So as a result, there's a normalization of the tissues over time. But it's very important for us to look at the scar examination. So if the scar on application of pressure like this tends to blanch, that means the scar is still active. So the application of silicone insert should be until the blanching becomes normalized. So you compare on the contralateral side, and if the blanching is not as significant as when the scar was active, that means it's the time you need to sort of start declining the use of silicone insert.
Thank you. The second question is, which criteria do you take into account to decide the amount of time a patient has to use a serial static splint?
So application of stress should be such that physiologically it should not create an inflammatory response. So I normally tell the patient to rate their discomfort.
Okay.
So I will not let the patient go home after fitting them with static progressive splinting. I say, wear that, go for coffee, come back, and then report me the discomfort that you're experiencing. If the patient is saying, well, I'm starting to have quite a bit of discomfort, that means the duration that I have applied the stresses to maybe a bit too long. So in such situations, you may not consider long duration. You may consider duration when it is not producing any physiological response such as inflammation and pain. And we need to educate patients as to looking at these symptoms after you have provided them with any kind of splint for that matter, whether it's dynamic, static progressive, or serial static splinting. So the tissues, of course, if you are excessively stretching, is going to cause an inflammatory process. So therefore, the forces should be such that they are not producing any hyper-reactive change that is producing inflammation. And there are 4 cardinal signs of inflammation. One is pain, discomfort, redness, and of course, pain then causes vasospasm and so on. So we need to educate the patient that this is the duration, and then the tissues have to be conditioned over a certain length of time until they become tolerant to the stresses for gradually longer periods of time. So starting off maybe with 10 to 15 minutes and then increasing with 5 minutes periods over time.
Right. Here there is another question related to that one. I think you have just answered that, but I'm going to read it. Considering the principle of external stress to support the healing process, do you recommend the use of splints in all cases, even as a preventive measure?
Well, it is a case dependent. So that's why I alluded to the fact that it's very important for you to understand the case thoroughly. So normally people don't, they just take the prescription and then start applying what the doctor has said, but never ever have a discussion about the case in details with the surgeon, because surgeons may not be able to give you every detailed information on a small little prescription pad. So if there are any doubts, call them and say that I have these questions, and you, of course, base your management based on the information that you have gathered. I always recommend that, when you're reading the OR note, highlight some key sections so that they work as a reminder to you on every visit basis that, oh, he has this, and I should be cautious about this. So the management is patient-specific, injury-specific, and this is something which we need to keep in mind. Rather than generalizing everything and say, okay,
yes.
Yeah.
There is another question. How do you manage home exercise programs and therapy sessions? How often do you see patients at your clinic?
So we see patients on the first day when the patient is referred. Of course, we emphasize that the patients are given thorough education about what has happened to them and what my role is and what their role is. So we have a handout, specific handouts on most of the conditions that we commonly see in a clinical setting. But if something is done differently for this individual, we'll write down the home exercise program. And now, of course, everybody is carrying a smartphone, even people are not smarter.
Yes.
To carry a smartphone, we ask them to record the specific instructions. And of course, they record on their smartphone, they'll follow it up. But on their next visit, which may be 2 weeks or 3 weeks, depending on the case may be, we'll ask them we'll download that smartphone recording on our system, and it is, kept in their on their file on our hospital careful system. So we have patients coming from different parts of the country. If the patient is capable of coming, we'll schedule them accordingly. But if not, then we'll refer the patient to a local center for management. So we tell the patient that the recovery is on their own responsibility,
Yes.
so much of mine.
You're right. I think it's essential to offer the patient resources to remember all the instructions that we give to them.
Right. And we educate that if there is any discomfort that they're noticing, this is our number, call back, and then of course we'll see you right away. So we don't have any waiting list. We'll schedule them, we'll see them. If they need any medical attention, we'll schedule them in the clinic. We have clinics every day, so we'll bring the patient in the clinic, get them seen by our surgeons as well.
Right. We have two more questions. Apart of the short-term field and the period of healing tissue, do you have any special guideline or criteria to identify which type of mobilization of splint will be better?
Well, you have to be very proficient in terms of doing your physical examination of that patient. And based on that, you examine, what exactly that patient's requirements are in terms of whether they need dynamic or static progressive, or whether they need dynamic assist splinting. So everything is based on your understanding of physical examination of that person, and it is based on the injury that the patient has suffered, and thirdly, it is based on the surgery that the patient has received. So everything is dependent on that.
Thank you. And we have a Brazilian therapist that is also participating, and she asked you that we know that because we treat PIP edema, it takes time to pass. How does you manage this edema with the dynamic orthosis? And what is the time of use that you advise to the patients?
So edema is something, if the patient has suffered finger injuries, we know that fingers have very fine lymphatic channels, lymphatic tubules. Finger injuries are often tend to retain swelling for longer periods of time. In olden days, we used to use string wrapping, and string wrapping used to be helpful. So we'll wrap the string from the tip to the bottom, and of the fingers will allow the person to perform active range of motion, so that we increase the gradient pressure of lymphatic return. And then, of course, we educate the person as to how they should do that at home. And then, of course, once the swelling is down, the mobility is much better. And then they have to keep a record of, we'll give them the tape, and we'll ask them to keep a record of their changes that are occurring as a result of motion, and then we'll custom tailor their management accordingly.
Thank you. So before we started the activity, we were talking with Shrikant about the reality of our country, that many of us receive the patients in a late stage, and many therapists find themselves having to deal with chronically stiff hands. Do you have any special advice for them, for us?
Yes, so I think what needs to happen, I mean, it used to be, we were in the same situation in Canada as well. So the Canadian Society for the Surgery of the Hand is a body that we have here, but we normally invite surgeons to attend our conferences, or if not, join the congresses with them as well. So we need to work very collaboratively with the hand surgery group, so that we have an interaction of us with them. Now, normally what happens is the therapists do not feel comfortable in presenting in the surgery conference. So I had presented many topics at hand therapist conferences, but after I realized that, we know all that, we can structure all that, but what about the surgeons? Where I'm coming from, the surgeon may not know. So I took a step, and I've been speaking at the surgeons meeting since, I think, 1985 or 86. So I have attended quite a number of surgeons conferences, even though I couldn't afford the registration fee. But I presented many papers, especially in talking about my idea. So you see the patient through my eyes. Your eyes are looking specifically. You have blind risk. You're looking at surgery and injury and X-rays, and you're saying, "Oh wow, the fracture looks great, but the damn hand doesn't move. How good is that hand which doesn't move, even though the X-rays may look great?" So I have presented a lot more controversial topics, such as this, the one which I presented today. And there are many other topics that I have presented which are controversial, especially educating the surgeons where I'm coming from, so that if the patients do well, they look better. I get a brownie point. And of course, if I get a brownie point, I've created a change in surgeon thinking process. So if you look at the overall surgical management of upper extremity condition, that a trial and error method, truly speaking. So we as therapists, we need to change that. It no longer should be a trial and error method. We have to sort of identify specific reasoning and specific rationale as to why I'm coming from or doing this and presenting this. So one of my recent articles that was published in European Journal of Hand Surgery, on zone-specific flexor tendon rehabilitation pitfalls, prevention and management. So, that went through back and forth because, the reviewers were questioning this and that and so on. So we had to, give a better and better explanation for surgeons to really realize as to what happened. So there are quite a few articles that I've written and published, which are again, controversial topics for people to think that, tendon injuries at this level, will behave somewhat differently. So this is something where we are coming from, and we should be educating the surgeons as to what steps we need to take.
Well, we have several messages to take home. I think it's essential, as you mentioned, to communicate, to let the others know what we do, what we can do, and to create and to build a teamwork so as we can arrive to better outcomes. So it's been like 1 hour and 40 minutes since we started this activity. I would like to thank to the audience for participating, and in name of the Argentine chapter of hand therapy, I would like to let you know our enormous gratitude to you, Shrikant. It has been an honor to count with you today, and I hope we can meet again soon. So I wish you a very nice weekend, and again, thank you for inspiring us.
Thank you. Thank you for giving me an opportunity. So thank you.
It's a pleasure. Shrikant, if you want, you can share your first slide so as people can send you, can take your email, because many of them wouldn't leave their email on the chat. So I think it will be better if they have your email.
Okay, there we are. So you can send me an email on info@handrehab.ca, or you can use Chinchalkar@hotmail.com.
So thank you, everybody. Thank you, Mariana and Shrikant.
Thank
Have
you.
a nice Saturday.
Thank you. You too. Have a nice Saturday. Thank you.